So, now that we've learned kind of from start to finish the mechanism of diabetes in general, type 1 and type 2, how do we augment this pathophysiology things that are occurring? And so we'll start with the drugs. And we'll first learn about the drugs that I've grouped known as the hypoglycemics. And I named them these ways because they can cause hypoglycemia or low blood sugar. And we'll start out with good old-fashioned insulin, straight insulin replacement. And there are a bunch of different formulations used, and they'll all depend on what part of the insulin issue we're treating. And we have very commonly used short-acting insulin Lispro, Aspart, and Glulisine. Lispro and Aspart are the most commonly used. We have our short-acting regular human insulin. We have not very often used NPH insulin. And then we have our extremely commonly used long-acting insulin Detamir, Glargine, and Degludec. And it's important to recognize, or what's important to recognize when using insulin in patients is the time of onset, the duration of action, and their relative solubility. Like I kind of stated before, insulin is something that's made by our pancreas, and it's made at a low level rate all day long. You can't just have zero insulin production. You need a low level of insulin secretion all day long, and then the insulin spikes have to occur with meals, okay? So we need low level and we need spikes with meals. That's our physiologic mechanism that occurs. So that means that our goal as clinicians is we want to try to mimic this physiologic mechanism as much as possible. And when you plot our short-acting and our long-acting insulins, you can see that rapidly absorbed insulin administered shortly before a meal peaks at about the same time as our postprandial peaks naturally within our pancreas. And then slowly absorbed insulins like Glargine has a delayed onset of action and a lower, wider peak suitable for kind of mimicking the low basal insulin rate all day long. In looking at our long-acting insulins, you can see that a subcutaneous administration of insulin, Glargine for example, that's not in like aqueous solution can lead to a constant rate of absorption, almost like a zero-order kinetic absorption, which mimics a continuous IV infusion almost. Under these kinds of condition, the plasma insulin reaches a steady state where the absorption rate equals the elimination rate. And essentially, there's no peak that's seen here. It's kind of just low-level, continuous all day long. So it provides really, really good fasting plasma glucose control, especially during the night when gluconeogenesis or production of de novo synthesized glucose by the liver occurs. And the way that this is achieved is by engineering insulin formulations to form hexamer depot preparations. Only free insulin, or these little green triangles, free insulin on their own, will be able to have an effect on their receptor. Large globs of hexameric insulin all compacted together first needs to dissolve into solution, into monomers, before they can have an effect or have an action. And so what we'll find is rapid-acting insulins, or like ultra-short-acting insulins, tend to be more in a monomer or even a dimer form, and longer-acting insulins tend to be engineered as multi-hexamer components to form depot preparations when administered subcutaneously. The first insulin I want to talk about is good old-fashioned, the oldest one we have, human regular insulin, which is just straight insulin that we make ourselves, that we've synthesized, and here it is. This insulin is available over the counter, and when you do mix it with zinc ions, like I said before, it is able to form hexamers and dimers. It has a moderate onset of action of about 30 minutes and can last up to 8 hours. It's not commonly used in an outpatient setting unless a patient is really poor or doesn't have insurance, which is really upsetting to me because most of my patients are Medicaid and Medicare, and I have a type 1 diabetic who has a job, but his job doesn't offer insurance, and he makes more than he can apply for Medicaid. So he's stuck in this like in between of he works but doesn't have insurance. And you'll see why this is ridiculous, but I have to manage him on NPH insulin and regular insulin as a type 1 diabetic. And you'll see why that's horrible here in a minute. But sometimes you gotta do what you gotta do. What I tend to find with regular insulin is it's not commonly used in the outpatient setting, but it is the most commonly used in an emergency setting. Like when a patient's inpatient or in the hospital, regular insulin is sort of the go-to one. When you inject this into the bloodstream, like an IV, it breaks into monomers very quickly. It separates from those zinc ions, and it acts like an ultra short-acting insulin, which makes it good for IV infusion because you can titrate it up and down. This brings us to very commonly used, I forgot I put this slide here. Because regular insulin also has been formulated into an inhalation, which tends to mimic ultra short-acting agents. And this is administered via an inhaler that goes right into the lungs, easily crosses the lung and alveoli because it has carrier particles with it, and can be a non-injectable version of insulin. I'll tell you, it's really not used very often. And you can see that, at least in studies, it shows that the onset of activity is comparable to our ultra short-acting insulins, like this one. These are used all the time, insulin Lispro. And ultra short-acting insulins were created because we wanted to be able to have insulin work right away, but not have to inject it into an IV in order for it to work fast. And the reason is could you use regular insulin as a short-acting agent? Sure. But most people find that you don't get the regular insulin's effect when you inject it subcutaneously for about 30 minutes to an hour. And when you're at Olive Garden and you see the waiter coming and they set down the big plate of pasta, you don't want to have to sit there for 30 minutes because you just injected your short-acting insulin and you have to wait for it to start having an effect and then you can eat, right? So they made these ultra short-acting agents. And insulin Lispro was engineered by switching two amino acid groups of regular insulin, which inhibits the formation of those hexamers, even in subcutaneous tissues. So therefore, its onset of action only takes about 5 minutes and can last up to 4 hours. And when you compare regular insulin to insulin Lispro, you can see that there's a much shorter time to peak concentration, but the duration of action does suffer a little bit as compared to regular insulin. Insulin aspart is very, very similar to Lispro, where one amino acid was changed, which also inhibits the formation of hexamers. Its pharmacokinetics, however, are essentially the exact same as Lispro. Insulin glucosine has two amino acid changes, where the lysine was replaced by glutamate and asparagine was replaced by lysine. Not terribly important that you remember that, but its pharmacokinetics are also not much different than Lispro and aspart. So it makes it easy. So I group those three together. One thing that you'll see here is you're going to ask me, okay, am I going to have to memorize that glucosine is 5 to 15 minutes and that aspart is also 5 to 15 and Lispro is 5 to 15, but the peak concentrations are a little bit different? No. Just remember they're really ultra short acting and they work pretty much right away. That's the biggest thing that's important. This brings us to an older insulin, which is one of our intermediate acting insulins, known as NPH. This is another one of those that are available over the counter, so it's relatively cheap, and you don't have to see a doctor in order to get it, especially if you don't have insurance. What they did was they took the regular insulin with the zinc and then added a protamine to it. And we'll learn over the series about protamine. But it's a very highly charged molecule. We saw that zinc and regular insulin can form hexamers, but when you add it to protamine, it actually forms crystals. And this makes it so that when you inject it subcutaneously, it reduces the onset of action even further, starting around 2 hours and having a duration of action up to 24 hours, with a peak at 12. Therefore, what we find is twice daily dosing, it can start to mimic the natural basal rate as well. Unfortunately, it doesn't do it very well. What we'll find is that it kind of mimics short-acting insulin and long-acting insulin at the same time, but it doesn't do both of those things very well at all. So it's kind of it's okay for short, it's okay for long, but kind of sucks at both. But we sometimes have to use NPH insulin in cases where patients cannot afford better meds. And this insulin can be mixed with others, like our regular insulin or Lispro and things, and you can mix them in like a 70-30 mix or a 50-50 or a 70 or 75-25 or whatever. What I find is no matter what drugs these use, you should really not use them. So you don't have to memorize these. You'll know that they exist because sometimes you might have to. I've never used them once in my entire life, okay? Because they suck. It's impossible. It is impossible to get somebody well controlled when you use NPH insulin or regular insulin. But sometimes it's the best we can do. This brings us to our workhorses, or our long-acting insulins. And the first of these were insulin glargine. Glarge sounds like large, long-acting, which is a modified human insulin where amino acid switches were completed, and these switches caused a change in the solubility. And when you combine it with zinc, like we saw before, it actually forms microprecipitates. And it does this at a pH of 7. So it's soluble at a low pH and forms precipitates at a pH of 7. What has pHs of 7? Our body, like our subcutaneous tissues. So when you inject this into your subcutaneous tissue at a pH of 7, it's going to precipitate out into crystals, microprecipitates, which will further slow down the absorption. Therefore, we find that the onset of action is 3 hours with no peak, and it can last longer than 24 hours. But these microprecipitates do pose a little bit of a problem. They take up a lot of physical space. What we find is that when you start to get around greater than 60 units at a time, the absorption will start decreasing drastically and it won't be as effective. It'll absorb almost way too slowly. And this has to do with physics. Maybe you've learned in the past that surface area and volume increase at different rates, where a volume increases cubed versus a surface area that increases squared. Me and my buddy had a talk once. He asked me, would you rather fight a horse-sized duck or a duck-sized horse? And I said, a horse-sized duck. And he's like, well, if it flies and it just hits you, I'm like, there's no way it's going to fly because the volume of the duck increased at a greater rate than the surface area that he would be able to get under his wings, which means he would be too heavy. You know what I mean? It's kind of the same thing here. But a horse is built to, I don't know. No, you're right. You're right. Okay. Well, but he's going to move a lot slower, so I'm going to see that peck coming. You know, it's not going to be like, bam. It's going to be like, bam. So I'm going to see it. I don't remember the argument in full, but that's kind of... But the same thing kind of happens here. If you inject more than 60 units, then the volume increases at a greater rate than the surface area for absorption. So it starts throwing it off. So what we do in clinic is once you get past 60 units, you split the long-acting into twice daily, so 30 units twice a day, rather than 60 units once a day. I hope that makes sense. I don't remember the argument. And you can see how this forms. When we inject it, it forms those microprecipitates, which have to dissolve, and then there's still hexamers, which have to break apart from hexamers into dimers still, and those dimers have to break down into monomers before they start having their action. And again, the goal is to create an insulin that mimics the basal rate of insulin. And so you can see here why NPH isn't a great medication for short or long-acting use. This is NPH here. You can see it kind of does long-acting, but it's not short-acting, and so it sucks at both. Then we have insulin detamere, which has also been modified to reduce solubility and generally has the same exact kinetics as glargine. And then we have insulin degludec, which is a modified human insulin with a single amino acid deletion, unlike insulin glargine. It is active at a physiologic pH. But the addition of a gamma amide linked to the gamma carboxylic acid of glutamate, which is also linked to a dicarboxylic fatty acid, allows for the drug to form multi-hexamers in subcutaneous tissues. Those multi-hexamers mean that it breaks down even slower. Also, the addition of those agents that I said before also allows this insulin to start binding to albumin, to also create an insulin reservoir. So not only do you have the insulin reservoir in the depot preparation that you just administered, but it can also bind to albumin once it's dissolved, creating another reservoir of insulin release. And what we find is that this long-acting insulin can actually give a duration of up to 42 hours. So very, very long-acting. You can also find that this drug, they make this drug as a part of a combination known as insulin degludec and aspart, Rhizodeg. Because what we find is in type 2 diabetics, if you use insulin, it doesn't mean that the patient has to use a long-acting insulin and then short-acting insulin before every meal and then also before bedtime, because that's too much. Most of the time in type 2 diabetics, all you need is one dose of short-acting insulin before the largest meal of the day, and then a long-acting insulin, and that's usually enough to control their A1C, less than 7. So they made this as a, hey, right before you eat that Olive Garden tonight, take this combination dose, which will give you that peak insulin release, and then over the next 24 hours or whatever, it'll give you your basal rate at the same time. I've never used this, probably never will, but fine. It's really expensive. I don't know. And all of these provide good options to patients, right? But nothing actually ever beats a continuous infusion of insulin that can change minute to minute, meal to meal. And this is why, especially for type 1 diabetics, in my practice at least, using all of the insulins before that we just talked about are a good way to bridge them to getting to a continuous subcutaneous insulin through an insulin pump. Pumps are by far the most effective control of glucose because they can sync with Dexcoms, which are continuous glucose monitoring systems, and automatically give you the perfect amount of insulin minute to minute, meal to meal. And so these insulin pumps are going to be the most effective way of mimicking the body's natural system the best. This is just a summary slide for you. And again, you don't have to memorize all the specific numbers, okay? Just remember which ones are long, short, ultra short, etc. Know some of the generalized numbers. So ultra short acting is going to work pretty much right away. Regular insulin is going to take a minute, 30 minutes. Long acting, it's going to take hours, but lasts all day. Those kind of general things. What's one thing I said about insulin? It's our storage molecule, which means insulin can cause weight gain, right? And that's one of the biggest side effects with insulin. Although it doesn't have a lot of side effects because it's a natural hormone, Weight gain is a big side effect from this, as well as hypoglycemia, which is probably the most important of them. Most diabetics actually don't feel too bad running at 200 or 300. I have plenty of them. Actually, when I get them in normal range, like 120, they're like, I'm hypoglycemic. My sugar's so low. And it's because their body's just not used to being at the normal levels. Their homeostatic set points changed. So they don't really feel too bad when their sugar's high, but the moment you accidentally dose too much insulin and they go low, they'll never trust you again, because hypoglycemia, low blood sugar, is very horrible feeling. And like I said, with weight gain, well, weight gain and what else? So I said that, like in type 2 diabetes, our issue is insulin resistance. So what happens when we start giving more insulin? It's going to work, but over time, what's going to happen? Their receptors are going to downregulate even more, which means you're going to have to give more insulin and more insulin. And not only that, it's going to promote weight gain, which is going to increase appetite and increase the nutrient problem, which is the underlying problem. So they're going to get weight gain, they're going to start eating more, it's going to worsen their metabolic syndrome and diabetes, give more insulin, and it's kind of this thing. So at least in my practice, I try to use insulin as little as possible. If I have patients who come in new and they've been on insulin for years, my goal is to get them off of insulin to get them onto newer, better agents. There's a lot of old-fashioned docs that still go to insulin first. Dr. Check loves insulin. I'm throwing shade. I am a GLP-1 fan through and through. I've gotten so many of my patients off insulin with some of the newer drugs. Check loves insulin, but it's not wrong. That's the thing. As far as standard of care is concerned, putting somebody on insulin is not a wrong decision. And Check will explain that to you as well. I'm not throwing shade, kind of am. So, also, when you inject insulin consistently in the same spot over time, it can actually cause, because it's a storage hormone, it can cause fat cells in the area where you inject it to increase fat production or storage more than other places, so you can get little lipodystrophies, almost seems like lipomas under the skin, which is aesthetically displeasing for patients. Cool. This brings us to our next class of drugs, the sulfonylureas, which are an older class of oral medications, and they actually work pretty well. We only use the second generation drugs anymore, which are glyburide, glipizide, and glimepiride. And in my head, I think of these drugs generically as being close to insulin as in a pill as you possibly can get. That's not technically true, but that's the way I think about it. And these drugs work by stimulating the release of insulin from beta cells in the pancreas. Remember before that we needed elevated levels of ATP in order to close this potassium channel here. But in this case, sulfonylureas bind to a part of the potassium channel, which we actually named the sulfonylurea receptor, and we named it because that's where we found out this occurred. But when bound, sulfonylureas actually block and close the potassium channel without ATP. It does it on its own. So you don't need ATP there. That's going to do what? It's going to decrease the membrane potential, cause depolarization, open those voltage-gated calcium channels, and force the release of insulin. So what's this picture telling us? This picture tells us that we don't need ATP, and therefore it doesn't matter if you have low blood sugar out here or high blood sugar, it's going to still release insulin. It's going to force the release. Yes?
Are these pretty selective drugs for these calcium or potassium channels?
They're pretty selective. What I will tell you is potassium channels in our body have a really low affinity in the sense where lots of different drugs can bind to potassium channels. Sulfonylureas in this case are very selective for this potassium channel, but other drugs that we'll learn, even like blood pressure meds that bind to potassium channels, can also bind this one. But these are pretty selective for this potassium channel. And so it doesn't matter what our glucose is in the bloodstream. It's still going to force insulin release. And so you can see that we don't need ATP. It's going to force the release regardless, is the right word, right? Regardless of if glucose is present or not irregardless. Regardless. Who wrote that on my board? Who did it? Somebody wrote irregardless on my board up at my office. Who did it? I think it's funny. See me after class. Regardless. And this is kind of comes back to your question. A mental note for the future is we will study other drugs like hydrochlorothiazide, for example, which can actually lead to the opposite of things. It can bind to and keep those potassium channels open, which decreases insulin release. And so like a blood pressure medicine like hydrochlorothiazide, HCTZ, can actually cause hyperglycemia. So we'll learn about those things in the future. The second generation drugs are not necessarily more efficacious than the first gen, they're just much, much more potent. Okay? They're administered once per day and are all generic, so they're very cheap. But just like insulin, since we're forcing the release of insulin, further resistance can develop over time, which will decrease the effectiveness of these drugs over time. It doesn't happen to an extreme in everybody, but it does occur somewhat in everyone. In addition, they can be a little bit more dangerous in the sense that you're now forcing the release of more insulin by the patient's own beta cells, which means you're basically causing the beta cells to overwork themselves to make more insulin. And anytime you have cells stressing themselves, it can lead to oxidative stress and inflammation and death of the beta cells. So compared to just administering insulin, sulfonylureas can induce beta cell stress and actually lead to death of the beta cells.
Could it also, like, administering exogenous insulin, would that, like, lead to an atrophy of the beta cells because it's no longer producing insulin?
Correct, yes. So that's a good point, and I didn't say it. But yes, if you administer insulin and your pancreas doesn't have to do that work anymore, those beta cells can atrophy. They don't necessarily die, but they can atrophy, which means if you were to just stop somebody's insulin right away, those beta cells are going to need days and a week or whatever to recoup and produce insulin again, which means the patient's going to go into huge amounts of hyperglycemia, potentially DKA and HHS. So you got to ask yourself what's more important. Would I rather atrophy the beta cells, or would I rather increase the stress and potentially kill them off permanently? So what are these drugs doing then? They're not treating any of the underlying problems of diabetes. They're just treating the result of diabetes, which is what old-fashioned medicine kind of used to be. And also, because it's releasing insulin, we can expect the same side effects of weight gain and hypoglycemia if we use too high of a dose, feeding into that vicious cycle, again, like we talked about before. And hypoglycemia can lead to things like confusion, bizarre behavior, seizures, coma. And when you treat hypoglycemia, you can usually just treat it with a hard candy or IV glucose if they're inpatient. And at our office, we have intramuscular administrations of glucagon, which you guys learned. Glucagon is the opposing hormone to insulin. But I'll tell you, most of the time, a hard candy does the trick. Now, if they're unconscious in my office, then intramuscular glucagon. Or if they're in the hospital, usually IV glucose. So when I use insulin, or when I use sulfonylureas, or even the meglinotides that we'll talk about in the next slide, I use them for the shortest duration possible to bridge them to better agents. Because these drugs are cheap. You can get them right now from Walmart for $1. So we'll use this until we can get the better ones covered and start using those and then get you off those. So they're really good bridging agents, and they have a very high ceiling of reducing blood sugar. Then we have the meglinotides, which give us more drugs in our arsenal, but they're still only okay, kind of terrible drugs. Repeglinide and nitaglinide. And the mechanism is really easy to remember. They bind to the same sulfonylurea receptor and have the exact same mechanism of action as the sulfonylureas. The reason that they're in their own class is because they don't have sulfa components in their structure, and they're much shorter acting. Where we could give glipizide or glimepiride once a day, you have to use these drugs multiple times, 3, 4 times a day. And you should expect then that you're going to expect that same secondary failure and side effects that you saw with the sulfonylureas and even insulin. I just copied and pasted these slides from the sulfonylureas. So they're good bridging agents. I never use the meglinotides. I have a patient on one who came to me. I hate it. He likes it. We're going to keep him on it. But they're good bridging agents, including insulin. Unless they're type 1, then use insulin, right? And then this last slide just shows our IM glucagon that we have in my office, which again is that hormone that essentially just opposes insulin. You're only going to use this if they're unconscious. Otherwise, hard candy.